Everyone, my name's Tom Prendergast. I'm a senior data analyst at the Health Foundation, working as part of the Network Data Lab program. And I'm here with two of my colleagues today from the NDL lab in West Yorkshire, Anna and Josh, and I'll just hand over to them to introduce themselves.
Hey Tom, my name is Anna Palczewska. I'm senior data scientist for the West Yorkshire ICB lead place, and I am fully on NDL work.
Hi everyone, I'm Josh. I'm a data engineer and analyst, also working on the Network Data Lab, and then I also spend some time working on our leads data model that we use for a lot of these projects.
Great, thanks Anna and Josh. So we're here to talk to you today about our work on the elective waiting list, which, as Rachel mentioned, was done using linked systems of data, so waiting list data linked to wider health use data and demographic data. So today we're going to be talking through, on the one hand, kind of our process of kicking off that research and scoping our research questions, and the results of that research, but we're also going to talk a little bit about actually working with waiting list data and the particular challenges that poses, both in itself and when you link it to wider health data. So as I mentioned, I work on a team at the Health Foundation called the Network Data Lab, or the NDL. So the NDL is a network of analytical teams that the Foundation funds around the country, and we work together to use links data to analyze key shared issues in health and care. So the 5 NDL labs are based in northwest London, in West Yorkshire, where Anna and Josh work, in Cheshire and Merseyside, in Grampian, and in Wales, covering the whole country of Wales. And all those locations were chosen for this project because they already had particularly advanced and extensive local ecosystems of linked health and care data that we could use to kind of study these common issues or questions of interest. And so we collectively choose a new topic to focus on every year, and for 2024-25, that topic was the elective care waiting list. So to start with the initial scoping phase for that work, so when we kicked off, we spoke with a range of stakeholders to form our research priorities, including the elective analysis team and National Healthcare Inequalities Program from NHSE. We spoke to GIRFT, Getting Right First Time, and also to leading health and care analysts elsewhere in kind of the think tank space, so from the strategy unit, from the King's Fund and Nuffield Trust, as well as liaising with elective care teams in the ICBs that the various NDL labs are based in. And the purpose of that exercise was to identify where there is gaps that decision makers would like to see filled, and in particular where there are gaps that the NDL, with its access to these extensive linked data systems, would be well poised to fill. And we also discussed those potential research questions with a panel of patients and the public who we engaged through the whole project lifecycle, so from forming the research questions all the way up to publication. And from those conversations, 3 primary topics of interest came out. So the first was around measuring the impact of waiting for elective care on patients and also on the health and care system. So that's, of course, something that would require linking waiting list data to wider data on interactions with the healthcare system. And that's something that not a huge amount of research has been able to do before in kind of a comprehensive manner. And then the second question was around understanding who is disproportionately impacted by waiting, both in terms of disparities in wait times and also regarding impact on health. So that was something that when we began this work and while we were working on it, there wasn't a huge amount of information out there on, of course, more recently, data on disparities in wait times has been released by NHSE on a monthly basis. And in terms of impact on health, that, of course, is also something that would require the same linkages as the first question would. And then finally, we heard that a key area of interest was quantifying or evaluating aspects of the weighting experience that aren't captured in RTT data or what are sometimes called hidden weights. RTT data in this case being referral to treatment data, so data that covers the kind of standard waiting list path from initial referral to secondary care to finally receiving treatment or the pathway ending another way. So after assessing the data that was available to us and the labs, we went ahead with the first two areas of interest. So the trouble with hidden weights is obviously, as the name implies, they are hidden, so they're not actually that easy to spot in data. And not all the labs had access to data that could approximate those parts of people's weights. So that's still sort of a bit of an outstanding area that we couldn't address, but we focused on the first two questions that we gathered. And so that resulted in three final research questions that we used to structure our work, all of which we're aiming to fill kind of the knowledge gaps raised by the questions that were brought up in our stakeholder engagement. So these patients were explored for all patients waiting for elective care in any of the NDL locations that we work with, regardless of what procedure they were waiting for. And first, we examined how long people were waiting, as well as the reasons that people are removed from the waiting list. And then we also looked at how much healthcare people used before, during, and after being on the waiting list. And that particular question focused on people whose pathways ended with treatment. So for each one of these questions, we examined how all of these metrics varied by demographic and health characteristics. One little thing we should note is that waiting times were defined slightly differently between NDL labs based in England versus those based in Scotland. Our colleagues in Wales didn't participate in this particular project, but in England, waiting times are defined according to the RTT standards, so starting with referral and from to secondary care all the way up to treatment. And in Scotland, they're defined using the treatment time guarantee standard, or TTG standard, which starts from agreement for inpatient or day case treatment to receipt of that treatment. So it cuts out the outpatient wait period. So the data sources that the various labs used varied quite a bit, as we can see here, but there are some commonalities. So for instance, all the English labs used extracts of SUS for tracing secondary care contacts and A&E attendances and similar things, and all used their local data on primary care events to trace GP appointments, and in many cases also prescriptions. And also all of them used the WLMDS, or waiting list minimum data set, to gather information on elective waiting times. So there's a lot of information in this table, and I'm sure there's stuff here that a lot of people here may be interested in, so we can share these slides after the session, and also all this information is available on the technical appendix for our publication that's on the Health Foundation website. So yeah, as I mentioned, all the NDL labs in England drew their RTT waiting times from local extracts of the waiting list minimum data set. So this is a relatively new data set. It's been around since late 2021. So this was kind of, there hasn't been that many opportunities to use this for kind of a major linked data project like this in the past. And we found that there are a number of quite specific challenges that are related to this data. So on the one hand, WLMDS data is submitted on a weekly basis, so there's many different records for each RTT wait time. Records are held in a couple of different tables. There's one on clock starts, one on open pathways, and one on clock stops. So all of that needs to be reconciled to kind of build a coherent pathway. Records might be inconsistent or duplicated over time and between providers. Again, it's submitted on a weekly basis, so validation requirements aren't as high as they are for the monthly RTT data. And also weights may have multiple clock starts for the same reason. And similarly, wait times maybe haven't had any data submitted for them for a very long time, but they lack a specific clock stop, so we don't know precisely what the final status of that wait was or exactly how long it took.
Tom, sorry to interrupt you. Could I just jump in? I just wondered if anybody else was having any sound quality issues, whether it was just me. Is it okay for everyone else? Can I just make sure that everyone says they're fine? and they say it's not all about me. Okay. So maybe just okay. Thanks, Sarah. Just double check that you're on mute if you're not Tom. Okay, lovely. Thanks very much, Tom. Carry on.
Right, no worries. Yeah, so to remedy some of these issues, we used a pipeline that was built by the NHSE elective analysis team to process the WLMDS and to facilitate its linkage to SUS. And that creates, once you've kind of run it through that process and linked it to SUS, a data set that they call the elective patients pathway data set, or the EPP. So the pipeline used to create that links information from all these different tables, and then it groups them by RTT periods and patient pathways defined by patient ID and treatment function code. And this allows for linkage of RTT periods with SUS events during the RTT period and with the same treatment function. But of course, even with this process, there are still quite a lot of challenges to using this data. So to talk a little bit more about that, I'll hand over to Anna and Josh.
Thanks, Tom. Hi, everyone. Yeah, so this is the overall pipeline that the elective patient pathways team at NHS England used, and then we sort of borrowed this and built on top of as well to complete our analysis. If we start at the bottom here, you can see in the blue, this was the waiting list data that we used. And as Tom alluded to, there are actually 3 data sets here of the clock starts, the open pathways, and the clock stops, which all need joining together and then removing a lot of duplication. At the top here in the green, we have our SUS extracts that we were using, which were essentially split by admitted patient care and then some outpatient data as well. There were a lot of fields within these that didn't match with each other, but essentially we just wanted to join what we could together to get an overall overview of what activities took place whilst these patients were waiting. We also had a challenge regarding a lot of fields that had been either removed or processed by our local desk row, which essentially meant that our pipeline wasn't completely like for like with the NHS England team's version, and this is where some of the changes had to take place. So if we move on, please, Tom. So essentially, this is an overview of the majority of the challenges we came across. Ideally, what you'd expect to see from these 3 data sets is that each patient would have a clock start, and then in the following week, they would receive their open pathways data, which would be updated each week if any changes were taking place. And then you'd have a clock stop when that patient received treatment or otherwise left the pathway through other means. But what we actually found was that only 14% of patients appeared in all 3 lists. A slightly larger amount just appeared in start and open. Some of these may not have actually meant to receive a clock stop yet, but one thing we saw was that some of these patients did actually end their pathway, but didn't receive a clock stop notice. And some of the ways we tried to figure this out was there was actually a clock stop date field within open pathways, but again, it might not always appear as an actual clock stop record. Then we had some patients that appeared in open and stop. A large proportion of this was down to our own data requirements. We didn't have waiting list data going back for all of time. And some points, if a patient had been waiting, say, a year since their clock start, we might be missing that initial one. So we had to try and derive when they actually started their journey in some cases. 31% only appeared in the open pathways dataset. Again, similar case, we assume or try and derive what their clock start was. And then some of these should have actually had a clock stop, which we also had to derive. And then a very small amount actually were available within the clock starts and the clock stops, but with no information in open pathways. So these were quite tricky to try and link to the SUS activity events. So essentially what we have is a large inconsistency with a lot of these pathways and their IDs, and we use this EPP methodology to try and link them. So if we move on, please, Tom. So essentially what we were doing here was defining what is a pathway within these data sets and how can we link them together to try and get the best picture of when these patients started their journey what happened within that journey, and then when did it end. We didn't actually have the pathway ID within our SUS data. So for anyone else looking to do a topic like this, if you have access to both, absolutely try it. But we only have this value within our waiting list data. So instead, to mirror how EPP chose their method, we linked on a basis of the patient ID, the clock start date, and the treatment function code, essentially with the idea that these patients shouldn't have multiple pathways with the same treatment function going on at the same time, and they should all have the same starting date. Again, there were challenges with this. Most RTT periods did have that clean starting date, where there was only one of them, but we started to see some challenges ongoing where essentially patients would have a start date, and then as the open pathways was updated, this pathway would receive a new start date, most likely in the future of the original one. And we just saw a pattern of shifting start dates, which essentially made it quite tricky to try and link all these pathways together. And in our first run of the process, we actually saw a lot where we expected to be the same pathway, but appearing as separate ones in our data. So essentially, what we tried to do was remove a lot of these overlapping periods that we thought were the same pathway, which involved a lot of shifting of start dates. And then one thing we did see, which was granted only a small amount, but we saw multiple clock starts for the same pathway as well. So for the most part, we followed the EPP methodology, but we also added some additional code on top of that, which essentially looked at the clock stop field. Was it a reported clock stop field? Was it a clock stop field that we derived? If it was reported, we chose to trust that date. And then when that clock stop date was derived, we started shifting some dates around again to try and essentially get everyone on the same timeline. And yeah, you can see at the bottom here, a lot of this date shifting came from multiple starts with small gaps. A really common example would be a patient having a start date of, say, 1 week, and then for the same pathway, having a start date 2 weeks in the future, just as an example. In reality, it's highly likely this is the same pathway, considering it's for the same treatment function code. And essentially, yeah, we just tried to work all this together. So if we move on, please, Tom, and I will pass to Anna. Thank you.
Thank you. Another issue which we spotted when we were trying to clear the multiple start states and basically playing with the clock stop and clock start was the status. We were hoping we can use the status to identify on which level of the journey is a patient, and there are like several statuses which basically tell the outcome of being waiting for the clock to start and then waiting through waiting for the treatment. And we have noticed that quite often we had situation when clock stop, it was reported with the status which was represented from the open pathways. And in the cases when we didn't have a clock stop and we had to derive from the open pathways, obviously that also came with the status from corresponding the open status. So what you see here, you can see two graphs. That the top graph is showing you a percentages of the different type of the status, and the last one is the label unknown, which we introduced to basically code all the derived clock stops because we didn't have the corresponding status for those for those periods. So in this case, you could see that around 50% of our records with derived clock stop didn't have a status, so we couldn't identify if the treatment was provided or actually was, for example, declined. But then when we look for the bottom graph, what you could see the highest bar, around 30%, are the people who had the clock stop reported and had the corresponding status, and these are the people who where the treatment was declined. And when you align those statuses with the waiting time, you would see that this group of the people who the treatment was declined obviously had the shortest time of waiting. We had around 20% of the people with those with reported status who had the treatment when admitted, and then over 20% with the people who had the status reported for the non-admitted treatment. Can you move to the next one, Tom, please? So then we decide that we will be trusting the WLMDS dataset for the RTT period, but when we need to bring a SAS data to retrieve the patient procedures. So once we consult this with our stakeholders group, we find out for certain procedures, sometimes the procedure which is on the waiting list coded in the ops field, it is intended procedure, but quite often it might change during the time, and then you might see the totally different code when the procedure was provided. Example in our case, in our study, was the laparoscopy for the endometriosis, because we were looking for the gynecology problems, and the codes which were provided by the team from Leeds Teaching Hospital, we couldn't see the corresponding codes in the SAS data. So what we find out that actually the codes which initially the endometriosis patient were sent for diagnostics were captured as a hysteroscopy in SAS. So we decided that we will be using SAS in terms of the date of the procedure and the final clock stop for our data, and we will be trusting SAS for eventually what the treatment was provided, especially for the inpatient. When we look for the coverage between those two data sets, so in waiting list, we've got around 60% of the procedure codes. In the moment when we start bringing the procedure codes from the SAS data, we increase that coverage to 95%, but only 70% agreed between the waiting list and the SAS treatments. We also observed that around 65% of the RTT period had the link to at least one SAS event. So it means we were able to identify the activities in the secondary care, which basically align with the timeline on that RTT period. And around 70% should have a SAS event based on the status code, but we couldn't find it. And also what we find out in the other way, that 26% of the SAS event only link back to the corresponding RTT period. And that was similar number which the EPP and HSE team did when they've done the analysis on the national level. Can you move to the next one, Tom?
So once we had all of this together and we started to look into these pathways and what was going on with them, one area of interest for us beyond the main objective of this project was actually just trying to find out why these multiple start dates were occurring within the WLMDS data. One thing we noticed anecdotally, just as we were going through these pathways, was that in a lot of cases, we seemed to see that these multiple start dates tended to occur whenever someone was admitted as part of their waiting list journey. So, for example, we might have a start date of X, and then they become admitted, and then their new start date actually becomes that admission date. So it could artificially shorten these pathways by anywhere from a few weeks to a few months in some cases. So we wanted to look into this a bit further. You can see this chart here essentially just showing the bars representing specialties and their count of records where patients have more than one start date. And then in the red line, we can see the percentage of those records where the patient was admitted. And the actual answer we came out from our theory was the most common answer when we're working on data, and it's that it's kind of the truth. You can see there's quite a large spike for trauma and orthopedic pathways, which is an example of one where we'd expect to see a lot of admissions, and then the same again for general surgery. But for the largest part, the specialties with the most multiple start dates, like ophthalmology and gynecology, for example, don't actually seem to see that many admissions. So there must be more than just this going on. I would like to stress as well, it's likely that this differs by provider. Here in Leeds, we don't actually have many provider organisations. A lot of it's done through Leeds Teaching Hospitals Trust, and then through some with Leeds Community Health and the Leeds and York Partnership. So within your specific areas, you might see different patterns here, although I have a general suspicion that this might be going on in quite a few areas. So yeah, we'll move on, please, Tom.
So expanding from the multiple start date, we start looking for overlapping pathways, because this is what we noticed that might be a factor to actually longer waits. And what we have found out that in Leeds, 15% of the patients have an overlapping pathways. And if we look for the waiting time, we've got around 80% on the single pathways who were basically met target 18 weeks, and we've got around 60% of those overlapping pathways which met the 18 weeks target. So then we try to look how the difference, what are the difference between the characteristic of the people having overlapping pathway or just single pathway, and we find out that literally ethnicity was a quite important factor here. So the people with Black and Asian have in general the longer waits. We also find out the patient with the long-term condition, they are affected, and then literally they increase from the 3% for non-overlapping pathways to 8% in overlapping ones. Can you go to the next one? So then we've been looking at the gynae problems. As you could see, the gynae was one of the three of the longest waiting list above the 52 weeks. So once we start looking for the healthcare utilization, you could see the top graph. We consider 3 times. So we look for the 3 months before waiting, we look for the during waiting time, and the 3 months waiting. We find out that the people who are waiting longer than obviously have the highest healthcare utilization during that waiting time. And when we try to stratify again those people to understand who is more likely and less likely to wait longer over than 52 weeks, we have found out that quite often children and teenagers, which is quite small group for gynae, but still they have a long wait. People from the deprived area, the most deprived area, the Black, mixed and Asian ethnicity, and the people with no long-term condition and a single long-term condition, and quite often fit patient. For the gynae, what is interesting and is contradictory to overall characteristics for the long waits, we find out that in this case, the older adults and then from the least deprived area, quite often white with the multimorbidity and severe frail, actually are the patients who are look faster in terms of the gynae problems. Okay, to the next one.
Yeah, and just expanding on some of these gynecology disparities. One thing we also did was compare ethnicities to ONS stats for the Leeds area on what percentages of, well, proportions of ethnicities we have in our area. And one thing we noticed was essentially for people of white backgrounds, you can see this trend here where the majority of, apologies, got some notifications, the majority of people fit in within that under 18 weeks time period. And then we see a downtrend where the number of people on these longer pathways starts to decrease. Whereas for people of other backgrounds, such as Asian, Black, and mixed, it actually increases. The larger share of people are actually on these longer pathways compared to the shorter ones. So there's something to investigate there. And then as well, just going back to the multiple start dates, we essentially saw that there were a lot of people with these overlapping pathways, some people having upwards of 3 waiting list journeys at the same time, and it had quite a stark impact on how long they were waiting. And you can see this bar chart on the right here, just trying to split these types of people up, alluding to some of the characteristics Anna mentioned previously. But we essentially see that there's a bit of disparity here where for some people with severe or moderate frailty, those that are older and have a large number of long-term conditions, it starts to balance out around about the 3 to 4 number of pathways mark. And essentially these people end up waiting quite a lot longer than those that don't have these concurrent pathways at the same time. If we move on, please, Tom.
Right, thanks so much, Anna and Josh. So now I'll just give quite a quick summary of the results from the rest of the labs as well. So what were kind of the overarching takeaways from the work. And yeah, picking up on disparities in wait times and how long different population groups waited for on average. So in all these cases, we're using median, judging by median wait times. So first of all, we found that although most waiters were waiting for more, 18 weeks or less in all NDL locations, still 27 to 33% of people, depending on the NDL lab, were waiting for longer than 18 weeks. That's quite a way off the NHS target of 92% of people coming off the waiting list within 18 weeks. And then when we broke that down, we found that waiting times differed most dramatically by specialty, neurology, trauma and orthopedics, oral surgery, gynecology, and ENT specialties in particular had particularly long wait times, although precisely which specialties had the longest wait times did vary somewhat by lab. And then in terms of population groups, unsurprisingly, older people, people with higher frailty and long-term conditions tended to have shorter wait times. This obviously isn't something we would necessarily think of as an inequality, but it probably rather reflects local prioritization decisions based on need. And also, as Anna mentioned, people who were waiting for more than one procedure tended to have longer wait times than people waiting for a single procedure. And otherwise, there did appear to be inequalities between ethnic groups and quintiles of deprivation in wait time. So, for example, we saw that patients who lived in more deprived areas in almost all cases had longer waiting times than people living in more affluent areas. And people with Black, Asian, or mixed backgrounds all had higher average wait times than white patients did. Sorry, just go to the next slide. There we go. So yeah, here we can see breakdowns of inequalities by ethnic group and deprivation in various different NDL locations. So the differences, as you can see here, so this is median wait times in days, aren't necessarily huge, and they do somewhat vary between labs and their precise pattern, but they are present. And most notably of all, aside from the fact that these patterns do more or less match up with the national patterns observed in NHS England in their recent data releases on inequalities in wait times. But also when we cross-tabulated them with other variables, we found that they actually persisted even when you take into account differences in age distribution and IMD distribution between groups. So for example, we can see here the cross-tabulation between IMD and ethnic groups and median wait times in days. So we can see in both these cases that even when you divide the cohort into the most deprived quintile and the least deprived quintile and compare the two, that the inequalities in wait times between white patients and then Asian, Black, or mixed background patients, they are actually recreated essentially within each IMD quintile. So it doesn't seem to be something that's just a factor of differences in deprivation between groups. And then also, given that age was such a notable stratifier of waiting times, We can also see here, we did an exercise here essentially where we created expected wait times for each ethnic group in each area based on the local age distribution of that group. And in all cases, generally the expected wait times were all relatively similar to each other. So even when you take into account differences in age, whereas differences were quite a bit larger when you looked at the actual observed wait times. And again, when looking at IMD split by age, we can also see these kind of differences between the least deprived and the most deprived quintiles still persisting within age groups as well. And not just being a factor of differences in age distribution between quintiles of deprivation. So the second question that we looked at is, why are people removed from the waiting list? So essentially, why do their wait times come to an end? Is it because of treatment? Is it because of a decision not to treat, for did not attend, for all those kind of reasons? So the results for this question were heavily affected by data quality and missingness. This is something that Anna and Josh went through in some detail before. This is essentially because of the missing clock stop problem. And so because of that, we found that in Northwest London and West Yorkshire, around 40% of reasons for waiting times finishing were basically, we weren't able to derive them. So we were only able to answer this question comprehensively in one NDL location, Cheshire and Merseyside, where this variable was filled out a little bit better and clock stops were more consistently present. We were only missing about 5% of pathway ends in Cheshire and Merseyside. And we found there that less than half of pathways, so around 48%, ended due to receipt of first treatment, while nearly a third ended due to a decision not to treat. And very few pathways ended due to did not attend, so it's less than 1%. But having said that, the rate of did not attends for the most deprived quintile was double that of the least deprived quintile. So this may be a factor that also lends itself to greater waiting times for the most deprived groups, given that this is a signal of possibly barriers to attendance for some groups that are greater than others. And once again, one of the most notable stratifiers of reasons for leaving the waiting list was specialty. So we can see that specialty level difference here. There's some not especially surprising results, like for instance that plastic surgery has the highest rate of clock stops due to first treatment, while elderly medicine very frequently sees pathways ending due to the initiation of active monitoring. But there's some curious ones here, including some very long waiting specialties like neurology, gynecology, and ENT having quite high proportions of pathways ending due to decisions not to treat. So this raises questions about why this is happening. Is this because the long wait caused someone to drop off the waiting list? Is it because problems are resolving themselves over time? Are alternative methods of treatment being sought? We can't really tell because, unfortunately, someone dropping off to pursue private options or other options isn't separately identified in the pathway ends data. Rather, that is something that would fall into the decision not to treat category. So although we can see like hints of patterns coming up, we can only kind of say so much about what exactly these patterns are telling us about why some pathways are ending some way versus others. And then our final main research question related to how much healthcare people use before, during, and after their waiting period. So this was limited to patients whose waiting times ended with treatment. And so what we found here is that aside from GP appointments and prescriptions, healthcare use was relatively rare across the cohort while waiting. And even after cost waiting, GP appointments in all cases substantially outweighed A&E attendances, despite an A&E attendance, of course, being a more expensive form of contact with the healthcare system than seeing a GP. And then otherwise, deprivation, once again, appeared to be associated with higher healthcare use in all time periods, so both before, during, and after waiting. But this pattern was strongest in emergency care categories and was strongest during the waiting period. And also, quite unexpectedly, healthcare use in many cases was observed to be higher before and sometimes after waiting than it is while waiting. So those patterns did vary by point of delivery and especially by specialty. So for instance, specialties where the typical cohort would be expected to be a bit older, such as elderly medicine, often used a bit more healthcare while waiting for treatment compared to before and after, but in many other specialties, we saw really quite a different pattern. So to zoom in a little bit more on some of those results, so this is an example from Anna and Josh's work in West Yorkshire. So we can see here cost-weighted activity associated with GP and A&E attendances per 100-person weeks before, during, and after the waiting period. So on the one hand, we can see this pattern that I was referring to, which is when considered on a weekly basis, you see that healthcare use tends to be highest in the period before joining the waiting list, lower while on the waiting list, and then kind of resurges slightly, but not quite to the same level after people are treated. This was relatively consistent across labs when looking at all specialties and patient groups together. As I said, when you break it down, sometimes those patterns change by age group or by specialty, but in the aggregate, this tended to be the pattern that we saw. One thing I should mention is that this includes the cost of A&E attendances, but not of emergency inpatient admissions. So they're very rare events, but they're quite expensive when they happen, so that would kind of bump up the cost weighting a bit. But nonetheless, they were still extremely rare events in the cohort. And then when we look in a little bit more detail at that post-treatment period and break it down by wait length, we can see that longer waiters had relatively greater increases in healthcare use after treatment compared to shorter waiters. So this is an example from our colleagues in Northwest London, and we can see for emergency care, so this is A&E attendances, use goes down compared to the waiting period for people who waited under 18 weeks, but it goes up for people who waited more than 18 weeks, and the relative increase goes up as wait length increases as well. We should mention here, typically the shorter waiting groups, they tend to be older, they tend to be more frail, so they do almost always use a lot more healthcare in absolute terms than longer waiting groups do, but what we're looking at here is relative differences compared to what they were using while waiting, and that's where this quite clear pattern emerges. And then finally, in terms of variation between population groups, as I mentioned earlier, deprivation seemed to be associated with greater healthcare use. So we can see here there's quite a clear gradient in this example. It's A&E attendances per 100-person weeks between the least deprived to the most deprived. So this was true in every time period that we looked at, so before, during, and after waiting, but the relative difference between the most and least deprived quintile was greatest during the waiting period, which is depicted here. Yeah, so those are our headline results. So since publishing, we published a couple of months ago, and we shared our results with various different teams in NHSE. We shared them with DHSC, the Centre for Perioperative Care, Royal College of Anaesthetists, and at a couple of different conferences. So we were at HSR, we were at the Royal Statistical Society conference in September, and we will be at HACA next week. And an early bit of impact is that for our colleagues in Grampian in Scotland, as a result of their work showing the impact of deprivation on use of healthcare while waiting, IMD has been made available as a consideration for clinicians' prioritization decisions there. In terms of our next steps, we have two pieces of follow work planned in the new year. So on the one hand, we'll be doing a more detailed analysis of NHSE's releases on elective waiting time inequalities. And more loosely, we're thinking of a project that investigates the factors associated with greater emergency care use after receipt of elective treatment. So looking to isolate the effect of wait time, because the current work, it gives us some kind of descriptive clues of those patterns, but this would be more kind of comprehensive addressing of that question. In terms of the future of the NDL, so we've moved on to our next topic, which is on housing and health, which we're completing the analysis for now. And then at the end of 2026, the NDL program will end with a final piece of work that's going to compile all the learnings from our previous projects. So that is all from us. Thanks so much, everybody, and thanks so much to Anna and Josh, and also to our many co-authors and acknowledgements. The NDL's a huge network, and we really would like to thank everybody involved. And also here's some QR codes for all the publications that we have released on this topic. So one briefing covering everything we went through today, plus a blog on some of the policy implications, and also a blog on working with the WLMDS.
Thank you, Tom, Josh, and Anna. That was excellent. I really enjoyed that. We do have. I'm interested to see the next topic. Actually, housing and health. With my public health background, I'm very interested in that. We have a couple of questions, but we've also got we've got a hand up. So was that a hand up to say well done, or was that a hand up for a question? I think it was. Would you like to ask your question?
It's a question. Sorry, my camera isn't working.
That's okay. We can hear you.
HCW. My question is basically, you know, you mentioned about the health inequalities and the ethnic minorities having like longer waiting times and everything. That's all actually known facts and about the clock start and stop. I think if we want to take one takeaway from this piece of analysis, what can we actually do to reduce the waiting times? Any suggestions?
Well, I mean, we have a couple of, on the one hand, data suggestions because kind of from our experience of working with the data, we think one of a serious problem is the fact that we can't really trace precisely which factors lead to longer waits. In particular, when you look at things like did not attends, which is known to be a very significant factor. But at the end of the day, when the existing data that providers collect and submit isn't kind of clearly telling us if that's the reasons for kind of pathways ending or for people needing to enter into multiple pathways or multiple referrals before finally receiving treatment, then it's not something that we can really use concretely. So improving data on clock stops and improving our understanding of why do not attends happen is, I think, one of the first things that we would probably suggest, because DNAs, even though they only made up a tiny percentage of what we were seeing as pathway ends, that's only typically after DNA rules will kick in that will happen. So sometimes that means there will be multiple did not attends to reach that point. So yeah, I think increasing our understanding of DNAs and doing everything we can to reach out to groups who clearly do face kind of greater barriers to attendance, I think is certainly one key area of intervention. Josh, Anna?
Thank you. Thank you very much. It's an excellent piece of work there, I should admit. But I think the problems, what you just mentioned, were like, you know, it's like all trust acknowledge it across the country. When I think about RTT waiting times, but nobody seems to come up with a solution to solve this. That's the issue here.
Yeah, certainly.
One specific thing that came out of our research that could be looked into as well was regarding these people that are waiting for multiple treatments at the same time. There seems to be a lack of interspecialty communication. One pathway may have specific treatments or prescriptions that can lead to delays on other pathways. And if consultants were able to communicate between each other a bit more effectively, at least for that specific group, their waiting times could be reduced as well.
Anna, do you want to come in, Anna?
Yes, very quickly, following what Josh said, from one of the consultations, especially for the Bradford Royal Infer, we've got a discussion around optimizing the communication between the different departments in the hospital, because it's not only DNA, but also it's hospital cancellation due to not receiving a test or the diagnostic before the next appointment. So the project we've been discussing was around how that can be optimized, and a patient who has scheduled appointment and the results did not arrive yet are scheduled in the near future. So that was also one of the recommendations.
Okay, thank you, Anna. So I know we are hit time, but there's still people in the room, so I want to keep going just for a few more minutes, if that's okay with my guests. You don't look like you're running away, so that's good. So Sophia, you've got a question?
Hello, yeah, I was just wondering if you looked at how all the different people were funded, So obviously in some areas people are very deprived, and so their funding for like hospitals and schools is done by like a calculation by the government. And I was wondering if that correlates with the NHS calculations, and that might be sort of systematically why their waiting times are so much longer, not because they're a minority or this ethnicity, but because the government is underfunding them in every area, not just the waiting times.
That's an interesting linking to finance is always brings in a whole a new dimension, which is obviously really important, and I'm sure has something very much to do with it. Okay, thank you, Sophia. I'm sort of rushing on slightly. We do have a couple of questions which we don't really have time to go through, but if I share my screen, maybe you could just, I think, and also we've covered off one or two as well since these were put on. Is there, if I could pick a question, I can hacker is something I've already done, and I'll come back to in a second. People are still here. Somebody is asking if you're particularly surprised by any of the results. So we're going to go with this one, and I think, and you can pick another one, Tom. So let's answer this one,
Sure.
and then we'll pick one more, and we'll follow the other ones up afterwards.
Yeah, sure. So I think one result that we were particularly surprised by is that when we looked on a weekly basis, how people's healthcare use while waiting was lower than it was before and after. Afterwards,
Okay.
obviously, we had some kind of post hoc rationalizations of why that would be and of why that's not surprising. But it's certainly something we weren't expecting going in. I think we were expecting to see spikes in healthcare use when people were waiting, and that we would see kind of increased healthcare use over time as people waited for longer. But it seemed to be in those. Longer waits seemed to more have an effect after people were treated rather than before that they were treated, which I think was
that's interesting. Yeah, that is interesting. Yeah. Would you like to pick one other question then?
I suppose just some quick ones. So we weren't able to pick up if there were supportive technologies used to prevent DNAs. That's a really interesting question though, but it's not something we could pick up. In terms of phone report, yes, there is. So that's available on the Health Foundation website, which had the QR codes for, and I can also post it in the chat. And then share the methodology for linking sus to WLMDS. So we can't actually share that because that's partially based on NHSE's methodology. But yeah, the elective analysis team there might be able to share. There's a question about gynecology as well, if Anna or Josh want to pick it up.
Anna.
So around the gynecology, that was overall for the gynae patient as overall analysis, but we also have for the hysteroscopy the separate one. And very quickly on the DNA, so in Leeds we've got the elective list validation, and there was a system proposed in terms of reminders and contacting the patient. So in Leeds there is something happening to deal with DNA and do something about that.
Okay, no, that's encouraging. And of course, lots of different things do happen in other areas as well, and trying to reduce the DNAs, ringing people up and so forth has seemed to be helpful. Okay, well, I will. People are definitely. I can hear those tummies rumbling. I'm just going to stop sharing my screen, and I will say thank you ever so much for coming in and sharing that with us. I've enjoyed the presentation and your findings, and I like the fact that it wasn't perfect in terms of what you found. Data's like that, is it not? And these and that's why it's so hard when people quite simply talk about data linkage, and if we link this with this, we'll be able to have all these answers and everything. It's never ever that simple. But unless you try, you don't discover what those issues are or what you need to put right for the future for these things to actually make more sense. So thank you. I'm just finish by just very quickly just fleeting through because I'm going to be seeing you again next week, and I think it's all three of you next week, and this is where you're going to be at, not in this locale. You'll be in probably a very similar locale to where you are at the moment, but for everybody else, this is Hacker 2025. That's a health and care analytics conference. It's linked in with the 10-year plan. So if you want to step aside from actually doing your local plans on to realize the opportunities and ambitions of the 10-year plan, come and see us, come and hang out with us. We'd be delighted to see you. We've themed it this year. We tried to trying to sort of theme it on these sort of sub themes, and the overall theme is rising to the challenge, analysis at the heart of health and care systems of the future, because we are so important. They could not do it without us. This is the lineup we've got. This is a few days old. It's pretty much like this still. However, and just a quick flip. If you can see yourself, you get a special prize. Tom et al. But this is your first morning. All of these to be confirmed. They're all in there now. I've been working really hard. I've been using all of my influencing skills to get people in the room, and they've come running once invited. And these are the keynotes as well. So these are there's going to be there. So we're starting off with Penny Dash. I think is going to be our opening talk. That's not true. She's going to be second on. These are the people, and we've also got Ben Goldacre, and we've also got closing it all off on Thursday. We've got Andy Orlowski. He couldn't keep away, so he's going to be joining us. Thank you, Anya. That's really helpful. Thank you, everybody. I've gone a little bit over, but you are so worth it, and thank you for coming. And I hope to see you again back here, telling us all about housing and health, because that's going to be a fascinating topic, and there's going to be lots of people interested in that. Very different from the quite a discrete sort of waiting list as well. So thank you. Enjoy your lunch. That's what I'm doing, and I'll see you next week.
Thanks
see
so much.
everybody else in 2 weeks.
Thanks for having us. Bye-bye.
Bye bye.
Bye.